Welcome to Critical Matters, a sound podcast covering a broad range of topics related to the practice of intensive care medicine. Sound provides comprehensive critical care programs to hospitals across the country. To learn more about our programs and career opportunities, visit www.soundphysicians.com. And now, your host, Dr. Sergio Zanotti.
Sepsis, defined as a life-threatening acute organ dysfunction due to infection, is a leading cause of morbidity and mortality in the world. Early identification and time-sensitive critical care interventions are essential to improve patient outcomes. In today's episode of Critical Matters, we will discuss the Surviving Sepsis Campaign, International Guidelines for Management of Sepsis and Septic Shock 2026. These guidelines are comprehensive, and today we will focus on key recommendations centered around methodology, early management, infection, hemodynamic management, and supportive therapies. For further details, we encourage our listeners to access the full guidelines and the executive summary for the guidelines, both of which are open access publications and linked on our show notes. Our guests today are Dr. Hallie Prescott and Dr. Bram Rochwerg. Dr. Hallie Prescott is an associate professor in Pulmonary Critical Care Medicine at the University of Michigan and a staff physician at the Ann Arbor Veterans Affairs Healthcare System. She serves as co-chair of the International Surviving Sepsis Campaign Guidelines and as lead for the Michigan Hospital Medicine Safety Consortium's Sepsis Initiative. Dr. Bram Rochwerg is an associate professor and critical care physician at McMaster University in Hamilton, Ontario, Canada. He's an associate editor at Critical Care Medicine and is co-vice chair of the Surviving Sepsis Campaign Adult Guidelines. Both are recognized clinicians, educators, and researchers with an interest in sepsis and septic shock. It is a true honor and privilege to have them today as our expert guests to discuss sepsis. Hallie and Bram, welcome to Critical Matters.
Thanks so much for having us.
Yeah, it's great. Thanks for the invitation, Sergio.
I would love to start with an overview of the guideline development. Maybe, Hallie, you can tell us about the committee composition, sponsorship of these guidelines, and the endorsing professional societies involved.
Yeah, sounds great. So the Surviving Sepsis Campaign Guideline Panel had 69 members. This was a truly diverse panel. There was representation from 23 countries, and 38% of the panel either currently or previously practice in a low or middle income country. And the sort of most common regions of the world that people come from are North America or Europe, but 35% of the panel comes from outside of those regions. So I think that was just super important because, there's huge, variation in terms of like resources and perspectives. And so, we had a good diversity of representation, which led to, really rich discussions. So in terms of those 69 members, 25 of them were appointed directly through professional societies that were invited to sponsor and appoint a representative. And then the others were appointed through the European Society of Intensive Care Medicine or the U.S. Society of Critical Care Medicine to really kind of like round out, expertise in the different clinical areas. So once, individuals are appointed to the panel, they then get assigned to a working group. We had 6 different subgroups in the guideline, and those were screening and early management, infection, hemodynamics, respiratory support, additional or adjunctive therapies for sepsis, and then a group that addressed goals of care, transitions of care, and long-term outcomes. Additionally, we had a patient and family panel. This was actually co-chaired by Bram and our other vice chair, Lenny. And this was great. They were, really involved throughout the process, weighed in with, their values, preferences, also helped us to prioritize outcomes. So within each of those 6 different working groups, the first step of the guidelines was to define and prioritize clinical questions to be addressed in the guideline. And those are all formed in this PICO format, meaning we define the population of interest, the intervention, the comparator, and then we prioritize the outcomes of interest, typically focusing on about 7 patient-important outcomes. We then do systematic reviews for each of the questions, and those are led by a research librarian in close collaboration with a methodology expert. There was one on each subgroup, as well as the clinical experts. Once that was completed, we then did evidence synthesis, where we extract data from the identified studies, do meta-analysis, and pre-specified subgroup analyses, as well as assessing risk of bias. And then we assess the certainty of evidence and complete standardized evidence profiles, all according to grade methodology. And in terms of assessing certainty of evidence, that really focuses initially on the type of evidence, whether it's randomized trials versus non-randomized study. But then there's different factors that can either upgrade or downgrade, and ultimately you're left with a certainty of evidence spanning from very low to high. After that's been done, we would then meet together in our subgroup to review those evidence synthesis and then use this structured process called the evidence to decision framework, essentially a worksheet that we complete where we go through a number of aspects before developing a draft recommendation. So we review the certainty of evidence, the balance of undesirable and desirable effects, the values and preferences related to those effects, the resource use, as well as implications for equity, acceptability, and feasibility. So really only after having this really sort of comprehensive sort of run through of all the evidence and the sort of, contextualizing that, do we then developed a draft recommendation. And anytime there's at least low certainty evidence, we formulated a graded recommendation that ranges from a strong recommendation, we recommend, to a conditional recommendation, we suggest, over to a conditional recommendation against or a strong recommendation against. And then in the instance of having only very low certainty evidence, those were really handled more on a case-by-case basis. So sometimes we made graded recommendations on very low certainty evidence, and other times we issue statements of no recommendation. And so there's a number of factors that go into that. That includes, different aspects of that evidence to decision framework, things like impacts on resource use, equity, feasibility, acceptability, whether we'd made a graded statement previously on this particular intervention, whether the intervention is widely available, and whether it's already in routine use. So there's a lot of different things that kind of play into that. And we have a figure in the guidelines, it's figure 1, I believe, that shows this kind of decision framework and how we, walk through it and decide whether to issue a graded statement versus a statement of no recommendation, and then the sort of very select circumstances under which we issue what's called a good practice statement, which is, something like clinicians should or health systems should do this. It's also important to recognize that, the implications of these types of statements are different. So these strong, we recommend, versus conditional, we suggest. And we've also included a table 2 in the guidelines to talk about the different implications. So for strong recommendation, this is really something that we should do for all or most all patients. There's really sort of less need for shared decision-making or contextualization. These are more appropriate for policy or performance measure, and also things for which probably research dollars are better spent elsewhere. By contrast, conditional recommendations, which are more common in the guidelines, those are really like the default practice, the rule of thumb. Most patients should get this, many would want this, but there's also reasons why, context matters, and, you should consider shared decision-making. These ones are less appropriate for policy or performance measure, and also areas where, importantly, research is still warranted and may change future guidance. So really important to understand the difference between strong versus conditional recommendations. All right, so after we have those draft recommendations, we all were very fortunate. We came together in person in March of 2025 and had 2 days of in-person discussion about the draft recommendations. That was critical. Make sure that, we hadn't missed anything. Also make sure that the language being used was clear and concise. And then the subgroups were able to take that feedback back, sort of meet again, and make sort of final tweaks to their statements before we commenced with voting. And so for a statement to show up in the guidelines, we require that at least 75% of panelists vote, and that among those people voting, that there's over 80% agreement. And, in true reality, we end up having greater than 98%, essentially all people voting on nearly every single recommendation that they were eligible to vote on. And then for all but just a small handful of statements in the guideline, we had over 90% consensus. So that's kind of the process in a nutshell. There's a lot of work and really a lot of rigor that goes into it, and following essentially the standards of trustworthy clinical practice guidelines.
Excellent. And as we were mentioning before we recorded, there are, I think, 129 recommendations. So obviously a lot of people involved, a lot of work, and both of you as co-chair and co-vice chair, I think, are speaking on behalf of the group. But through you, I want to thank the whole committee for all their work for something so important. You talked about greater recommendations and the implication that these have in terms of practice. You also mentioned good practice statements. I also saw that there are a group of in our practice statements. Could you comment on that, Hallie?
Yeah. Thanks for bringing that up. So this was something that we brought in, more formally and systematically this time. So there's a lot of scenarios where we have only very low certainty of evidence, and even some places where we had, really no evidence at all and had to issue a statement of no recommendation. And we know how frustrating that is to the field, right? You read a guideline and it says, oh, we have no recommendation about this. So we essentially asked the question of, would it be helpful to the field to have additional information on the panel's practice? And wherever we thought that would be helpful, we did a survey of the panel, just to say, in your routine practice, do you do this, or how commonly do you do this? And we report those out. So those are always start with the statement of in our practice. And so they're clearly presented as, not being formal advice or guidance, but certainly for scenarios that are, there's a lot of sort of, context variability and limited evidence, I do think that is probably helpful information. So I think there's 13 different interventions for which we provide these in our practice statements and just report what the panel is currently doing with that intervention.
And these obviously highlight also the uncertainty we have in clinical practice. We don't have answers for everything, but I did find them actually instructive as I was reading, because it gives you a little bit more context and information of where people are practicing and what still needs to be studied and perhaps requires more data to make formal recommendations. The other aspect I wanted to ask before we dive into the recommendations themselves relates to terminology. And obviously, calling things by the right name is always important when we talk about a syndrome such as sepsis. So you've defined for the purpose of these guidelines sepsis through the SEP3 definition, but there's also additional terminology that is important for understanding these recommendations. Could you comment on these?
Yeah, absolutely. So we have used these terms of definite, probable, possible, and unlikely sepsis. And really those are meant to have clarity of language when you're sort of talking about this common scenario in clinical practice where, the patient shows up and initially, before you've even talking to this patient, you really don't know what they're presenting with. And then, over time, as you gain more information through your history and your exam and sort of the initial diagnostic evaluation, you have this kind of evolving clarity in terms of what the diagnosis is. And so when you think about, the sepsis 3 definition, it's really not getting at that. Really, it's really trying to say, what is the definition of sepsis? And so we use these terms to sort of clarify kind of where we are in the process of diagnosing a patient. So definite sepsis means essentially sepsis is confirmed. Probable sepsis means you have a very high suspicion for sepsis, and this is actually the most likely diagnosis for this patient based on what you know from history, clinical examination, and the diagnostic testing, and that alternative diagnosis is felt to be less likely. And then possible sepsis, this is a moderate suspicion. This means sepsis is one of the possible diagnoses being considered, but that an alternative diagnosis is also likely based on history, exam, and diagnostic testing. So we wanted to be sort of precise about what those meant. So we spent a fair amount of time actually kind of workshopping those definitions, again, really trying to be clear, particularly very early on when we're talking about recommendations related to screening for sepsis, when to initiate antibiotic therapy for patients.
Excellent. Bram, I would like to get some comments on the screening and early management recommendations. There are several, but I would like to start with performance improvement programs, which, by the way, is something that Hallie has talked on the podcast before, and we'll link this in the show notes.
Yeah, thanks, Sergio. And wow, every time I listen to Hallie go over the process, always impressed by the rigor that goes into these guidelines. There's no doubt that it benefited from the group of experts and as comprehensive approach as we took. Each of us, in addition to serving on leadership, also participated with one of the individual subgroups. I'll be honest, hemodynamics was my subgroup, which we might talk about soon, I think. And it was not screening and early management. But as Hallie said, we were there for discussions that were ongoing in our in-person meeting in Chicago and aware of some of the intricacies of these recommendations. And I think this is really, the epitome of the guideline is that using performance improvement programs to try and get better at things like screening and operating procedures, improving quality improvement strategies. This is how we do better for the future, right? And some of these, you can see that the evidence for some of these is less robust. Although when you come to quality improvement strategies and screening, there is fairly good data to show that this improves, at a hospital level and a systems level, our management of patients with sepsis, and also improves outcomes. So I think this was fundamental. It was building on the recommendations that were made in 2021 in terms of ensuring that performance improvement programs were part of any hospital-based approach. And, it does recognize that there's going to be some variability depending on the hospital and the system around how this is operationalized, what's practical, how it's monitored, but it's important to undertake.
And when we look at the history of the guidelines over 20 plus years, from my perspective as a clinician, what's been a true lesson is that it's not so much that what we do changes over time, but having a standardized approach, evidence-based approach, does improve the care of these patients. And we should keep pushing forward. And I think this is very important for our listeners to push this forward if you don't have it in your hospital system.
Absolutely agree, right? You're 129 recommendations, Sergio. You're always going to find recommendations that you agree with, ones that don't, ones that are consistent with your practice. And, it's important to chat through those details, but to know that, again, as you say, a robust process, methodologically rigorous. And we know that use of these guidelines, translation of these guidelines into bedside practice has improved outcomes of sepsis patients over time. And we have data to back that up. So I think it's really important to make sure that QI piece of things is not lost.
I would like to ask you about diagnosis of sepsis. I'm old enough that I was actually in training when there was a paradigm shift in sepsis and people started talking about it as a emergency, as a time-sensitive disease that actually had a higher mortality than many other diseases that we were treating in the ICU, such as acute MI, that were treated with that time-sensitive nature. So obviously, early diagnosis and intervention is going to be very important. In terms of the use of biomarkers and blood cultures, where do we stand today with the recommendations?
Yeah, thanks, Sergio. Two things I think when it comes to sepsis diagnosis and quotation marks. We're on a podcast. You can't see me do the quotation marks in my hands. But, I as Hallie mentioned, I co-chaired the patient and family partnership group that were associated with the Surviving Sepsis Guidelines. And even beyond, you're not going to diagnose sepsis early unless you screen for sepsis. And, each of the patient and family partners all had a story, their journey with sepsis, and you could date each of them back to the fact that they probably weren't screened for sepsis or sepsis was not diagnosed early enough and might have improved their outcomes, limited the impact of critical illness on their trajectory in their lives if it had have been. And so, we have both recommendations for screening, and you can see ones that recommending certain tools like NEWS and MUSE and SIRS over QSOFA, which, although had some data earlier on, perhaps less robust data compared to the others when it comes to screening. And then also, so the importance of early screening, is crucial. When it comes to then to your question around the diagnosis of sepsis, we also, provide some recommendations around blood cultures, which still incredibly important, and biomarkers. And, the biomarkers piece that you bring up, I was in the room for these debates and they were widespread and robust. And, there's a lot of excitement around biomarkers, justly so, for the diagnosis of sepsis. And no doubt, Sergio, I feel like this is going to be the future, right? Is that 5 years from now, 10 years from now, 15 years from now, we very well might be able to translate sepsis from a clinical diagnosis diagnosis to a biomarker-based diagnosis. But the reality of the situation is, at least, and we did these robust reviews informing it, looking at MDW and other novel trade-based, industry-based diagnostic tools, is that the data is just not quite there yet to recommend for one of these novel biomarkers to diagnose sepsis. And so we recognize that sepsis is still a clinical diagnosis. It's not that we're going to take one biomarker and be able to decide on diagnosis for sepsis. And, there's promise from these biomarkers, but we require further research, further investigation, looking at diagnostic test characteristics before we're at a point that we can recommend for these.
Could you comment on blood cultures and what is recommended today, just as a reminder for everybody?
Absolutely. So anybody with, probable definitive sepsis, the recommendation is to send for blood cultures, ideally before antibiotics, but it's not necessarily absolutely the case. If it's going to decrease the time, inappropriately delay the time to antibiotic administration, especially in that golden hour, not to defer. But if you can, send blood cultures before, but certainly to send blood cultures for all patients with suspicion for sepsis.
What about blood lactate measurement?
Absolutely. So still recommended for blood lactate measurement in patients with sepsis. I believe it's a conditional recommendation. I have them up in front of me. Lactate's not a perfect measure by any means, and there are definitely patients with evidence of sepsis or hypoperfusion that don't have elevated serum lactate, and we can perhaps discuss targeted resuscitation around normalizing lactate levels when we get to the hemodynamic subgroup. But there's no doubt that lactate can be one of those pieces of information that can help in terms of guiding even initial fluid resuscitation as well as diagnosis. And so we do make a recommendation for measuring lactate for sure.
One of the, I would say, more debated or controversial over the years recommendations relates to initial fluid resuscitation, and we will talk about hemodynamic management a little bit later. But this is in this section in the guidelines. Could you talk about that?
Sergio, it's, listen, always, I hope Hallie doesn't mind me saying, but probably the most controversial and talked about recommendation in the entire guideline is the, evil 30 mils per kilo. And perhaps I shouldn't do it, but inevitably end up going on social media after the publication of the guidelines. And no doubt, I think it's important to understand the criticisms that are out there and appreciate the diversity and perspectives. And but we had a lot of discussion as a guideline panel around these recommendations around 30 mil. And I think that there's been important evolution over years. This was a strong recommendation in the past, maybe more contextualized now as a conditional recommendation, meant that it's meant to apply to most, but certainly not all. And there is data to support, sufficient fluid resuscitation. And perhaps some of the more recent trials, this has now been indoctrinated. It's part of what we do. And by no means are we, again, especially with the conditional recommendation, suggesting that all patients need this exact amount, that there's something magical about 30 mils per kilo. And you'll notice that there are a number of remarks that specifically follow this recommendation. Consideration for individual patient characteristics in selecting the initial fluid volume. Clinicians should perform frequent ongoing reassessments and closely monitor patients to avoid harms and under or over resuscitation. And that it should be weight-based, based on ideal body weight and specific considerations in those with elevated BMI. So, again, I think it's important to acknowledge that patients with sepsis most often require an initial fluid resuscitation. And, barring some better number, this is still what's framed within the guideline, but those considerations should not be ignored and need to be incorporated into any contextualization of this recommendation for sure.
Yeah. And I believe a lot of the pushback also comes from a misunderstanding of what the guidelines are intended to do, which is guide, right, and give general information for what be appropriate for most patients, but always use at the bedside your clinical acumen and try to individualize the care for that patient that you are dealing with.
That's such an important comment, Sergio. 100% agree. And, it's tough to make guidelines that are meant to be applicable in academic centers, community centers within the United States and Canada, beyond low middle income countries, where there's an intentional commitment to applying these recommendations in the low middle income setting as well. And so, perhaps if you're at a site with advanced hemodynamic monitoring and POCUS skills, and, there might be different knowledge translation and application of some of these recommendations compared to other settings. But within those challenges, trying to come up with recommendations that are globally applicable. Again, we followed a comprehensive process and did our best. And exactly as you said, these are meant to be guidelines, especially conditional recommendations, Sergio. They're meant to be considered and applied within the context of the patient in front of you.
Excellent. Hallie, I would like to shift the gears to infection management, which obviously is a center point of our care for sepsis, and start with the timing of antibiotic initiation in the hospital.
Yeah, absolutely. So the antibiotic timing recommendations, these are summarized in Figure 2 of the guideline. And I would say that these are generally, completely consistent with the 2021 guidelines. There's some, sort of small tweaks to language, again, always trying to be sort of more clear and concise as able, but really consistent with previously. So if sepsis is definite or it's probable, meaning it's your leading diagnosis, you should administer antimicrobial therapy immediately, ideally, within an hour of recognition. And then when sepsis is possible, this means, you have a moderate suspicion, but you're also entertaining and evaluating other diagnoses. The sort of next steps are really recommended to be stratified based on how sick the patient is, right? So if a patient is in shock, this is really, too sick to guess wrong. So the recommendation is administer antimicrobial therapy immediately. Of course, continue to look for other causes, stop those antibiotics if it turns out to be something else. But then in patients, who are less sick, right? Shock is absent, sepsis is possible, we recommend a rapid assessment of infection versus non-infection causes of illness, with this goal to administer antimicrobial therapy within 3 hours if concern for infection persists. So this is really trying to carve out time to do, additional history, additional physical exam, x-rays, ultrasounds, blood work. There's typically, a number of additional things that can be completed within that time window that are going to allow you to either increase or decrease your pretest probability, like how likely is it that this patient has bacterial infection, and then make a more informed decision about whether to prescribe antibiotics. And so I would say at a high level, right, this framework is really trying to balance two things. One, the urgency of treatment that we know is particularly present in patients presenting with hypotension and shock, but then also being mindful about overtreatment and not, just sort of treating everybody across the board. So that's really the sort of intention behind that framework.
Absolutely. And I do believe that, just to reemphasize, the likelihood of sepsis being the diagnosis and the severity of our patient are going to probably push us to earlier and broader. And this is not meant to mean that you have a elevated white count and everybody gets antibiotics, right? Which I think has been the way some people have interpreted this over the years and has led to maybe overusage of antibiotics with all its potential complications.
Yeah, exactly. Right.
In terms of empiric antibiotic coverage, there are three areas that I found quite interesting and worth discussing. If you could comment on antibiotic coverage, which is empiric for potential MDR pathogens, multi-drug resistant pathogens, antifungal empiric coverage, and anaerobic empiric coverage.
Yeah, absolutely. Yeah, I would say, like, in general, at a high level, I think the evolution that we're seeing in the guidelines is really having this kind of greater focus on antimicrobial stewardship during that kind of like initial time when you're selecting the empiric coverage, right? Because there's sort of two things you're trying to do. One, you want to cover the likely pathogens, but I think there's also increasing recognition that, when you treat with kind of broader than needed antibiotics, not only are there these kind of like theoretical harms that can happen in terms of, promoting antimicrobial resistance, but there's also like direct kind of harms that it can occur to the patient due to this kind of off-target coverage. So this kind of comes out, I would say, most clearly in the anaerobic coverage, and these are brand new recommendations. Like, this was not a PICO question that was addressed in prior guidelines. But we asked about empiric anaerobic coverage, and there's really like emerging data showing that for patients with like a very low likelihood of an anaerobic infection, so for example, lung infection or a urinary tract infection, it's very unlikely that those sites of infection are going to be caused by an anaerobic pathogen. And in those instances, treatment with empiric anaerobic coverage is associated with worse outcomes, right? So like increased mortality, and this is really thought to be mediated by disruption and depletion to the healthy gut microbiome. That's like an incredibly important, essentially, organ and is important for resisting infection. And this is, there's also like a wealth of preclinical evidence that also kind of supports what's also been observed in human patients. So we now have these paired statements, a conditional recommendation to avoid empiric anaerobic coverage in patients with a low risk of anaerobic infection, and then to include anaerobic coverage in patients at high risk. So this means, like, if it's a lung infection, if it's a urinary tract infection, avoid anaerobic coverage where possible. By contrast, if it's an intra-abdominal infection or a necrotizing infection or this deep-seated gynecological or obstetric infection, you would want to cover for anaerobic pathogens. And when you think about implementing this recommendation, it's not only about like, oh gosh, well, should I add something like, metronidazole or clindamycin, these things that are prescribed very specifically for their anaerobic coverage. It's really also about trying to be mindful for the gram-negative coverage that we're prescribing, because there's huge differences in cross antibiotics prescribed for gram-negatives in terms of whether they also come part and parcel with anti-anaerobic coverage. So, for example, piperacillin tazobactam, has, very strong coverage against anaerobes where, cefepime does not. And so it's sort of just adding this to the conversation to, sort of think about being mindful of that, avoiding it where feasible, while of course still being, mindful of your hospital antibiogram and, sort of the resistance patterns in the, populations that you care for. And then this sort of same, I would say, just high level, theme of, treat what's likely and try to limit treatment in what's unlikely. We see the same thing, for MDR pathogens. So, you want to sort of limit your MDR pathogen coverage to patients who are at higher risk and avoid that coverage in patients who are lower risk for any particular MDR pathogen. And then antifungal coverage, this one's also kind of interesting. So previously we had paired statements in the 2021 guidelines, like, include it for high risk patients, but like avoid it in low risk patients. But I think the issue is that even in high risk patients, right, clinical trials enrolling patients with hospital onset sepsis, in theory, high risk for antifungal infection, even those types of trials that are really trying to zone in onto the and target the high risk patients do not find benefit of empiric antifungal coverage because this is, quite rare, and we don't have sort of great tools at present to identify who are the highest risk patients to be able to provide that empirically. And so I think like the guidance is really evolving there. So the suggestion, conditional recommendation is to not provide empiric antifungal coverage, but then we have a remark, you know what I mean? This can be considered on a case-by-case basis. And it's really trying to sort of match the guidance with how commonly you might do something in practice. So, with these kind of two conditional recommendations, it might be like, oh, most of the time I don't, but maybe a third of the time I do. And it really should probably be less than that, right? More on a case-by-case, very sort of, less commonly should you be including that antifungal coverage. And so the guidance has really evolved that this is now really covered in a remark as opposed to our own sort of conditional statement regarding antifungal coverage. So hopefully that sort of demystifies maybe a little bit like how those, the guidance has evolved over time.
And I personally really like the use of the remarks because it helps you really define a little bit better who would be high risk and really encourages clinicians to think at the bedside, right? I mean, it's not necessarily you do one thing for everybody, but I mean, you should be thinking, is this patient at risk for anaerobic? Is this patient really at risk for a fungal infection. And in those cases, and if they're in shock especially, I would be more aggressive. So I love that. So thanks for clarifying that.
Oh, yeah. Thanks so much for the comment. I mean, this is honestly what you spend so much time in that in-person meeting discussing, is really trying to finesse, right? Like if your recommendation becomes a whole paragraph, you've kind of lost. And so it's really trying to keep those recommendations short, but then, add this more nuance, kind of like nudge people towards what are the things you should be factoring in when you make this decision at the bedside for, the individual, patient right in front of you or taking care of. So yeah, that's really the goal. And that's what we sort of strive to do. And so, hopefully those remarks are helpful to people.
Absolutely. We don't think, when I say we, I'm talking about physicians, and especially probably that much about pharmacokinetics, pharmacodynamics, but our clinical pharmacist colleagues do a lot. And there was a very strong recommendation for the administration of beta-lactam antibiotics. Could you talk about that?
Oh, I think you're talking about the strong recommendation for prolonged infusion. Is that right?
Correct.
Yeah. Yep. So this was upgraded. So this was a conditional, we suggest during the 2021 guidelines, and this was upgraded to a strong recommendation. And really the basis for upgrading this is that there's now, several clinical trials, high quality. So you're bringing together multiple, high quality clinical trials and showing that there's a mortality benefit. And so that's really, this kind of higher certainty evidence is what's bringing the strong recommendation. And the rationale for this is that, after that initial rapid bolus loading dose to kind of get your drug levels up, use of prolonged infusions has better, essentially pharmacokinetics, pharmacodynamics than doing these kind of intermittent bolus infusions. And so this maintains your, drug levels at a safe and effective a dose for a longer period of time. And then again, bears out that this is associated with the most important, improved mortality, improvements in patient-important outcomes. So yes, this is now a strong recommendation, and overall summarized as being moderate certainty evidence.
We tend to start broad, especially in sicker patients, and we tend to love to keep our antibiotics going on forever as intensivists. Could you talk about de-escalation and discontinuation of antibiotics?
Yeah, absolutely. So there have been, like a number of recommendations on this, very topic over the years, right? So in 2021, we have recommendations that this should be essentially assessed on a day-by-day basis. In general, we suggest shorter over longer durations of treatment. Now we have a strong recommendation that when the cultures come back, you should de-escalate. And that means either sort of narrowing the coverage, maybe switching antibiotics, or, dropping antibiotics that are no longer necessary. So I think in day-to-day practice, essentially, the antibiotics should never be kind of like a set and forget. This is something that you should review each and every day of like, do they still need what they're on? Is there something that can be stopped or discontinued or switched to sort of narrow the spectrum of coverage?
Anything else you want to add with antibiotics before we move on to hemodynamic management?
No, I think we're good. I think we covered the key aspects there. Yeah, thanks.
Excellent. Bram, I would like to talk about hemodynamic management, which obviously could be a podcast on of itself, like many of these topics, but really encourage all our listeners to read the paper, but also look at Figure 3, which I think summarizes the management and all the recommendations very nicely. But could we start by talking about blood pressure monitoring and target blood pressure in terms of the MAP?
Yeah, great, Sergio. Totally agree. This was the working group that I sat on formally, and we had some great discussions. It was always a bit hard with scheduling because we had members from across the world. So I can think of many times sitting in my house in the basement at 5 in the morning or 6 in the morning, having passionate discussions about hemodynamic management and sepsis, just given the realities of the time change and making sure that we had as many folks as could be there. This has obviously evolved a fair bit over time, the idea of invasive versus non-invasive blood pressure monitoring in patients with septic shock. And, the discussions were heated already around the necessity of having arterial access versus using non-invasive. And you're probably very aware of the New England Journal study results from the EverDAX study that was published, sort of while the manuscript was in process, we definitely incorporated this into our considerations, but didn't really change the sentiment of the recommendation, recognizing that, there's probably a role for both, as non-invasive or invasive, and individual patient factors can likely influence that. And you'll see that reflected by the fact that we made a conditional recommendation for using either invasive or non-invasive blood pressure monitoring. There's a few considerations in the remark here. Again, using those remarks to our advantage as much as possible, talking about those on high dose vasopressors, escalating doses, multiple vasopressors, the need for frequent arterial blood sampling might all be reasons why one might think about placing an arterial line. But given the potential for complications, pain for patients, all those other factors, recognizing that it's not the be all and end all, and certainly based on study results, doesn't change outcomes. I think this was most impactful for the folks because it's part of who we are as intensivists. It's what we do. We put in lines and we monitor patients closely, but I think it's inherent on all of us to reevaluate some of those fundamental features that we take for granted within the ICU, and evaluating practice and seeing what's best in terms of improving patient outcomes at the same time.
And in terms of the MAP, there's also new recommendations for the target. Could you talk about that?
Absolutely. So, listen, I feel like the challenging topic, similar to the 30 mils per kilo, there's 65 is a relatively arbitrary number in terms of MAP targets, and I think that there's recognition that is the case. We certainly still kept that number for the majority of patients, but recognize that it's impossible to target exactly 65, and suggested that a 5 millimeter mercury variance, maybe between 65, 70, again, a conditional recommendation, is most appropriate for the majority of patients, but again, a conditional recommendation to suggest that there might be a subset of patients for which this doesn't apply. We made a specific second recommendation for those over the age of 65 based on Francois Lamontagne's 65 trial in JAMA, showing potential benefits of slightly lower MAP targets in older adults. But there's still ongoing uncertainty in this area, Sergio. And the reassuring part is that we're going to have more data addressing optimal MAP targets in the coming years. You're aware perhaps of this mega MAP randomized control trial currently enrolling, led by Paul Young and the Australians, and then Francois Lamontagne also doing ongoing work around optimal MAP targets. So, we have what we have for now, and I think it's reasonable and probably consistent with practice in terms of what most folks do, aiming for, somewhere in that 60 to 70 range, depending on perhaps some other patient-related factors around age and others. But I think that we'll have more data addressing this question soon.
Perfect. Fluids, another topic that we've been talking about for a long time, right? And it seems to go in like a pendulum back and forth. But we do have more data over the last couple of years. And could you talk about the fluid type recommendation? And then a little bit about albumin.
Yeah, absolutely. Maybe we'll start crystalloids versus colloids, because I think it's a good centering debate. We haven't touched the recommendations around starches and gelatins from previous iterations. There's not really new data. We made strong recommendations against, and I think that's consistent with current practice as well. The albumin one has shifted a bit, and again, passion discussion within the room of the surviving sepsis experts around the role of albumin. When you look at systematic reviews of the data that's out there, there's certainly no evidence of harm, but at the same time, also no evidence of benefit. And a lot of the point estimates, when looking at a number of the patient-important outcomes, fall right on the line of no effect. And so a lot of the discussion, again, centered around the fact that you're unlikely to cause harm by giving albumin, but at least, taking that low middle income perspective, thinking about costs, choosing wisely, the rationale behind administering an intervention that is much more costly compared to crystalloid without evidence of benefit becomes contentious. And so that's what informed the conditional recommendation against giving supplemental albumin. Now, if you told me, Sergio, that you were running a randomized control trial specifically looking at the role of albumin, perhaps some recipe of albumin and crystalloid, I would certainly be willing to randomize my patient, again, recognizing that there's probably unlikely harm. But at least for the practitioners reading this guideline, without further data supporting the rationale for administering something that's much more expensive, I would say stick with crystalloid in the majority of patients, and that's certainly consistent with the recommendations that we made. Now, when it comes to which crystalloid, Oh my goodness, what a long history of, I'll tell you, prior to 2010, 2015, nobody really cared about this crystalloid debate or the discussion about which crystalloid was optimal. But we sort of recognized that, normal saline, again, using my invisible quotation marks that you can't see, is far from normal, has a chloride and sodium concentration much higher than that of human plasma. And so the rationale goes is that perhaps balanced crystalloid is able to get away from some of these complications like hyperchloremia and metabolic acidosis and might be more beneficial. You can look at the largest randomized control trials, PLUS, BASICS. They don't show an improvement in patient-important outcomes like 90-day mortality when using balanced crystalloid. But when you do the individual patient data meta-analysis and use a Bayesian approach, there's maybe a signal, once you pool all the data together, of a slight benefit of balanced crystalloids. When I say balanced, I mean those Ringer's lactates and plasmolites of this world. And so that's what informed the conditional recommendation to use. Also, again, from the low middle income perspective, the cost is about the same between balanced crystalloids often in many jurisdictions and saline. So we felt like it was okay from that perspective. Maybe as a little teaser, Sergio, I'll let you know that we just completed a randomized control trial specifically looking at Ringer's versus saline in patients with septic shock. We're going to be presenting the results at CCR in Belfast in June. So, maybe further data that could be incorporated into subsequent versions of Surviving Sepsis.
Excellent. And we'll definitely, have you back to talk about that post-June. So what about hemodynamic monitoring from the perspective of fluid resuscitation guided by measures, serial lactate measurements, and capillary refill time? And then I have a question for my POCUS crowd friends.
I feel like, even with the previous iterations of the guideline, we've moved away from the static measures of hemodynamic response to fluid administration. Those CVPs and Swan-Ganz catheters have quickly become less used in our unit and a more focus towards some of these dynamic measures like passive leg raise and systolic pressure variation, pulse pressure variation. And so you'll see, again, a conditional recommendation for using these dynamic measures to guide fluid resuscitation. Certainly in those with an elevated lactate at baseline, targeting fluid resuscitation to improving lactate clearance, again, consistent with the previous recommendation. We said, hey, if your lactate is elevated to start with, try and normalize that lactate or target normalization of lactate with fluid resuscitation. The cap refill one, I also find interesting. I was actually just speaking to a few students about this earlier, is that despite building evidence, I still feel like it's probably underutilized in most centers. I'd be curious to hear if either of you use routinely cap refill when targeting and guiding resuscitation in your patients. Now, maybe things like Andromeda 2 that have recently been published, building on Andromeda 1, demonstrating the benefits of using a protocol that incorporates cap refill will help change that paradigm. You'll see we made a conditional recommendation for using cap refill time as one of your tools to guide fluid resuscitation. But I don't know what the operational barriers are, but I still find that it's not used widely. Maybe I need to commit even with my own practice of using it more. I guess, Sergio, there's probably not one tool that folks will use to guide their fluid therapy, but some combination of these dynamic measures, cap refill, lactate clearance and precipitated around the idea of a test bolus, looking for improvements in these parameters is probably the optimal way to go and recognized in the recommendations.
So point-of-care ultrasound, obviously, at least in North America and Europe, has really taken off in the ICU. I understand kind of the perspective, but a lot of POCUS fans were kind of surprised that there's not a formal statement that says that use POCUS and you will save every patient with sepsis. Could you comment on that?
Yeah, no, and listen, I use POCUS as part of my everyday practice as well, and I know that there's a role as using POCUS as part of our toolkit in guiding therapy. And again, Andromeda 2 will help support that idea that there's benefit in incorporating it as part of it. Andromeda 2 aside, there's despite the fact that another one of these interventions that we think it makes intuitive sense that using this to help guide fluid resuscitation will improve outcomes, there's not the robust RCTs that are maybe addressing this. And, it's not prioritized, at least within this guideline iteration, as one of our PICO questions of interest to explicitly address the role of POCUS. But listen, between you and I could certainly see it being prioritized as a question for subsequent surviving sepsis guidelines, especially as the uptake and use and incorporation into study protocols has increased over the last few years. So certainly to those POCUS enthusiasts out there, I would say, there's building data. Obviously, I don't think any of the recommendations that we provide here are against or not consistent. And, one could consider grouping it as one of those dynamic measures of guiding fluid resuscitation and keep an eye out perhaps for subsequent iterations of surviving sepsis as that evidence base builds. I wouldn't be surprised if we see it incorporated more formally.
Perfect. In terms of vasopressors and inotropes, could you comment on the timing of initiation of vasopressors and then tell us what the recommendations are for first line, second line, and third line agents?
Yeah, of course. The figure 3, I think you made reference to, is a really helpful tool. I think Hallie put many hours into creating this figure, but I'm glad that she did, because it's a helpful guide. And recommendations are one thing, but when you have 129 of them, having a quick reference point always helpful. Something you can print up, perhaps put in your unit or on display in a clinical area could be helpful. And so no doubt you'll see within the recommendations is that we did recommend for fluid administration prior to vasopressor initiation, but there is a remark clearly there that, for some patients, you don't have the luxury of waiting. Those with florid hypotension that present quite sick, sometimes this has to be done synchronously in terms of administrating fluid and vasopressors. But if the luxury is there, then one should at least start with fluid therapy before initiating vasopressors. When it comes to vasopressors, again, not a lot of change, Sergio, and since the last iteration. We have pretty clear data that norepinephrine is beneficial as first-line vasopressor across shock states, but definitely in septic shock. A lot of it, when you compare it in those old CAT trials to epinephrine and the VAST trials to vasopressin, dopamine, and the SOAP trials, a lot of it came down to not necessarily improvements in mortality outcomes with norepinephrine, but less tachyarrhythmias compared to epinephrine, dopamine. And so a lot of the rationale behind using norepi as our first line, and you can see a consistent, strong recommendation for using norepinephrine as first-line vasopressor. When it comes to second line, there's probably increasing data for vasopressin, and my practice has actually shifted in the last few years as perhaps having a lower threshold for initiating vasopressin. You might look at some of the trials that have examined supplemental vasopressin in addition to norepi, demonstrating initially folks thought it might reduce mortality, might improve acute kidney injury, and it didn't. But that being said, when you pool estimates together, maybe an impact on some of those important outcomes. Most importantly, adding vasopressin leads to less tachyarrhythmias. And again, that's quite clear based on, there was a meta-analysis in 2018 in JAMA that showed that. And so we make a recommendation for starting vasopressin as a second vasopressor with increasing norepinephrine requirements. There's one of those in your practice, in our practice, around what threshold folks use for initiating vasopressin. But again, I'll be honest with you, my practice is that it's certainly dropped in the last little while to lower doses of norepinephrine. I'm thinking about adding vaso, and especially with that rationale of less tachyarrhythmias. And when you start getting now down to third vasopressor, we made a conditional recommendation for epinephrine. Certainly, this is the case where you're running into a very high mortality once you're starting to initiate 3 different vasopressors.
Excellent. Any comments on inotropes?
Even in those with suspected cardiac depression, there's still a recommendation for starting with norepinephrine. The recommendations around vasopressors make life easy, right? Is that you have a patient with shock in front of you. For most indications, you can start with norepi. A lot of the trials that examine the optimal vasopressor included patients with shock of any etiology. I think we said within the recommendations you could consider norepi or epi as first line in those with septic shock and comorbid cardiac dysfunction. If despite norepinephrine or epinephrine as vasopressor, as we both know, they provide some inotropic, conotropic support as well, you're still not achieving lactate clearance or adequate perfusion, we did make a recommendation for adding inotrope support at that time, and either dobutamine or milrinone. There was insufficient evidence to make a a recommendation for one or the other.
And there's been a lot of talk in the literature, well, not in the literature, but a lot of, I think, discussion among intensivists on using midodrine in different contexts and also methylene blue in multiple contexts with shock. What do the recommendations say on these two?
There has been increasing discussion on both, and you see variable practice when it comes to both as well. Even in my center, I see variable practice when it comes to midodrine. And when it's midodrine, there's the role perhaps in those that are on vasopressors, active vasopressors, still in the resuscitation phase, and then some advocate for using midodrine in the de-escalation phase, helping to come off those that are on decreasing doses of vasopressors. Especially the motivation there may not be improvements in outcomes, but if you're able to liberate a patient from vasopressors sooner, you might be able to get them out of the ICU, which could be important from a systems perspective and cost effectiveness perspective. Unfortunately for both agents, the data is not quite there sufficient enough to provide recommendations for either. We did discuss quite a bit related to both. But again, reassuringly, Sergio, as I'm avidly aware of ongoing randomized control trials, both Canadian-led and others that are addressing both interventions. And so hopefully we'll have a little bit more guidance around each of these in the coming years. And who knows, hopefully within the subsequent Surviving Sepsis might have data to inform recommendations. It wasn't for a lack of trying this time. We did do systematic reviews. We chatted through things, but felt like that there wasn't enough out there to provide recommendations.
Perfect. I would like to switch gears and talk about adjuvant and supportive therapies. Hallie, could you make the comments on what is the most current recommendation on corticosteroids?
Yes, absolutely. So very consistent with prior, we have a conditional recommendation, a suggestion to use intravenous corticosteroids in patients with septic shock. I think there's a lot of aspects about sort of steroid treatment that people wonder about, like when do you start it and what dose, and like should you also be using fluorocortisone, and like when do you stop it? And so it's really hard to prioritize all of those many questions into the guideline. And so we tried to, give a little bit more information beyond just this conditional recommendation to use it in septic shock through these in our practice statements. So we have almost like a full paragraph sort of describing, how the panel is currently using it, whether as an intermittent dose, which is what most people are doing, versus a continuous infusion, at what sort of threshold of norepinephrine equivalence people are starting it, or sort of after how much time on vasopressors, and then whether people are using fluorocortisone and how they're stopping it. So again, hopefully that provides more information, but yeah, guidance really consistent with prior, suggestion to use this, appears to definitely shorten duration of shock and, may provide mortality benefit as well. Perfect.
Any comments on antipyretics?
Yeah, so this was interesting. You're always trying to sort of address new questions in the guidelines. And so this is something that had not been previously addressed previously. And so we were looking very specifically at the use of antipyretic therapy for the purpose of, improving patient important outcomes, right? These are things like mortality, duration of shock, event-free days, things like that. And there's really not evidence that antipyretic therapy does that. And so we're pretty careful in the wording of this recommendation, right? So this is a conditional recommendation, a suggestion against the use of antipyretic therapy, or surface cooling for the purposes of improving clinical outcomes. But of course, if there's kind of like, symptom control issues, you can sort of still use it on an as needed basis, but essentially just says like systematically, like sort of managing temperature at a certain level for all patients with sepsis, doesn't seem to, confer patient, improvements in patient outcomes that we can identify in the literature thus far.
And I'm going to lump several treatments together here because the recommendation is the same. Which are vitamin C, IVIG, vitamin D, and blood purification. Could you just make a comment on these?
Yeah, so these are all things that we look into, for the guidelines, really we have suggestions against all of these things. I will say the one area that is probably different in an area of kind of more active research and where things could change in the future is blood purification. I think it was like pretty much the exact same day that the guidelines came out. This Tigers trial was released in Lancet Respiratory Medicine. And so again, this was, looking at a very specific population of patients with septic shock and a high endotoxin activity and multi-organ failure, but did find that this treatment was associated with a high probability of mortality benefit. So it seems like maybe there's like very select subgroups of patients who may benefit. Of course, we did not have that data available at the time that we did the review. So I would say that, vitamin C, IVIG, vitamin D, all of those we suggest against. And I'm not aware of a lot coming down the pipeline. Blood purification is absolutely something that feels like more of an evolving field. And it may prove to be that there's, very select groups of patients for whom there may be benefit. And we'll have to address that again, in future guidelines.
And the last therapy I wanted to ask about was active fluid removal, which I understand is a new recommendation.
Yeah, absolutely. So we have a conditional recommendation, a suggestion to use active fluid removal or deresuscitation in patients after sepsis resuscitation. And to be honest, this was an area where I think we really kind of heard the patient voice come through. And I think we even sort of, mentioned this in the narrative write-up. It says our suggestion for active fluid removal was influenced by input from patient representatives who placed a very high value on avoiding edema. So I don't know, in clinical practice, this comes up all the time, right? Patients and families asking like, why the edema, why swelling? And it's very sort of bothersome to patients, and I think there's also, some data that it also, impedes functional recovery. And of course, that makes good sense if you're sort of carrying around extra weight and it's already hard to, get up and moving after septic shock. So that certainly, influenced when we sort of think about how the patient values, come in through that evidence to decision framework. So yes, new conditional recommendation. And then, we have, of course, more remarks on this one too, where we talk about what this looks like. So typically this would be diuretics, but if that's not effective, then there are other, means like through ultrafiltration. And then a number of different factors that we point out to consider when thinking about active fluid removal, including cardiorespiratory function, vasopressor dose, sort of like, are they at a point where it's safe to start deresuscitation? And then also looking at things like the exam, peripheral edema, weight, fluid balance to determine patients who may benefit.
Excellent. As we close our discussion, I wanted to pose a question to both of you, and then we'll start with Hallie. Most impactful new recommendation in your opinion? This is impact at the bedside.
Yeah, so for me, I think it's probably these new recommendations related to the anti-anaerobic coverage. And I think that's because it's just sort of like a new area. These kind of off-target effects of antibiotics in the microbiome, I think, is something that's, really emerged of recent, has certainly influenced my clinical practice, and I think very important to patient outcomes.
Bram?
I don't know, I thought long and hard about this one, and I think I have to go back to the hemodynamic subgroup, which is maybe biased by it, but the one that I had the most passionate discussions around, and perhaps around this invasive versus non-invasive blood pressure monitoring. I don't know where the pendulum is going to land and what's best, because I fully support the idea that there is still a subset of the population that we need to make sure that we have invasive arterial monitoring. The other caveat to this is that we talked with our patient family partnership group and those that had experienced septic shock. And, from a patient perspective, things could go both ways, is that having a cuff going off every 5 minutes also could be very uncomfortable. And some patients express that there might be a preference actually for arterial cannulization, but then granted that the actual process of placing the arterial line can be painful and expose patients to complications related to that as well. And so I like the recommendation that goes both ways, but it will be interesting to see how that evolves over time. And maybe if I can sneak in a second, I also like the idea of moving perhaps a little bit away from administering albumin and a conditional recommendation against. This again, early in my career, I probably used much more albumin supplementation in patients with sepsis and septic shock. However, recognizing and having participated in these evidence synthesis, understanding the differential in cost and lack of clear benefit, I've certainly moved towards using less and find this updated recommendation more consistent with my practice as well.
Excellent. The second question is most important or impactful old recommendation as a reminder for all our listeners from previous guidelines. And we'll go first with you, Bram.
Good question. I think it comes down to sepsis screening. And again, this was the common theme heard from our patient and family partnership group, is that if only the clinician had thought about sepsis early on, because we all know as a syndrome, it presents in so many different ways. And we know the importance of that golden hour, few hours, and immediately following diagnosis around early administration of antimicrobials and fluid resuscitation if needed as well. And so I think that the main recommendation that jumps out in my brain, having participated in that and for so many, is the importance of screening all of our patients for sepsis in order not to miss this diagnosis.
Perfect. Hallie?
Yeah, so great question. And I think for me, it really goes back to the antibiotic timing and also the initial fluid resuscitation recommendations. I think just sort of over and over and over again, right, we learned that sepsis is this time-sensitive medical emergency, and the faster we can take care of the problem, the better, sort of prevent all the kind of, downstream progression and complications. And this is actually kind of what makes me, a little bit sad about all the debate about the 30, ml per kg recommendation, is because this is really about sort of trying to get on top of the problem and really fix the problem. And the vast majority of patients tolerate, 30 mLs per kg just fine. And many of them are then sort of fixed, like blood pressure is stabilized. And so when people kind of push back against this, it'd be like one thing, I'd be totally happy if everybody kind of transitioned maybe more sooner to a personalized resuscitation approach. But what I'm really concerned, happens instead in clinical practice is that they do this kind of like slow roll, right? Like they give 500 mLs, I'll check back on the patient, but then they get tied up in another patient's room. And so the patient kind of smolders along and, sort of just doesn't sort of resolve the hypotension. And that's really problematic. And that's really the reason for this kind of pragmatic, upfront treatment. And then for patients, who on a case-by-case basis have a lot of risk factors or, prove themselves to be sicker and ongoing hypotension after that fluid bolus, then you can transition to a personalized approach. So I think really, screening, like Bram mentioned, and then really prompt treatment with antimicrobial therapy and fluid, those are sort of like the golden three things for sepsis management.
Excellent. We like to finish the podcast usually with a couple of questions that are unrelated to the clinical topic. Would that be okay?
Yeah.
Sure.
So I'll go with Bram first. Is there a book that has influenced you significantly or that you have gifted often to other people?
I appreciate the question. I do a crummy job of reading either for work or I obviously read a lot for work, but finding time for fiction, nonfiction that I enjoy. I wish I did a better job. My wife gets into bed every night and reads, and I don't know, she's always bragging about it, not bragging, but with the two of us where she's allowed to brag, having read 20 or 30 books a year, and lucky if I get to one or two while we're on vacation. I guess if there are a subset of books that I do enjoy, it's probably in the nonfiction, and I'm a bit of a history of medicine nerd. I loved reading about, how we used to practice 50 years ago, 100 years ago, and then learning about all the ways that we became proved wrong, that those were silly things to do, and it looks so backwards now. And I guess the reason I like this and reading about this so much is to think towards, 20 years from now, 30 years from now, what folks are going to look back at what we're doing now and think how backwards we've been practicing and what we're doing. And I guess when it comes to history of medicine, one book that had a profound effect on me was the biography of William Osler. He's a Canadian physician, you might be familiar with, and really brought that bedside clinical exam to the forefront. And not only that, but he was actually born and raised in the same small town in Ontario that I was. So I sort of feel that connection to him. So if maybe that's my thoughtful response here, is the William Osler biography.
Perfect. I mean, a lot to learn from William Osler, and truly a father figure in North American medicine, right? I mean, he practiced, I think, for many years in Hopkins. So for sure, we will include that link to that biography. Hallie, you've been on the podcast before and we've talked about books. So I want to ask you about music today. What music album, and I'm old school, call it an album, or playlist would you want with you in a prolonged isolation period, either on a deserted island or in a new pandemic? Hopefully not.
Yes, great question. Yeah, so my sort of favorite artist right now is called Monrovia. This guy, so I think his real name is John J. Lowe. He was born in Monrovia in Liberia in Civil War and then was adopted into the U.S. and just got this amazing kind of personal story. But he's an amazing singer. I heard him on the radio maybe like a year ago and then was like, oh, I really like this. So I jotted down the name so I could look it up. I looked the guy up and then when I was looking him up, it was like, tickets go on sale. He's coming to Ann Arbor. Tickets go on sale in 2 days. And so I got tickets and I saw him, I think it was in November, and he was just totally amazing. Lovely guy, really sort of compelling backstory. So recommend checking out his music. I listened to it on repeat.
Awesome. I never heard of him, but I definitely am curious now. Next question for you, Bram. Tell us something you have changed your mind about over the last couple of years.
Medicine related, Sergio, or anything?
Your choice.
Well, maybe I've done lots of medicine, and even my book example was medicine related. So maybe I'll go lighter this time around. We're big sports fans, despite being up in Canada, follow NFL and Major League Baseball and everything quite closely. And I have 4 young boys between the ages of 10 and 14. And I guess, between following the Toronto Blue Jays and the Buffalo Bills and the Toronto Maple Leafs, I felt like the boys asked me, I say, you'll definitely see a championship sometime in your lifetime, no doubt. But, the way the Blue Jays lost so awfully last year and the way the Buffalo Bills seem to be so close and never quite make it, I guess I'm not so sure that my boys will see a championship or one of the teams they like in at least my lifetime. But who knows, Sergio? There's always the beauty of being a sports fan is there's always next year.
There's always hope. Yep. So we'll see. I can sympathize with you. I was born in Buffalo and remember the 90s when I think it was 4 or 5 Super Bowl losses in a row. So who knows, right? Maybe. Last question for Hallie. What would you want every listener to know? It could be a quote or a final thought to close the podcast.
Excellent. Okay, yeah, I'm going to give 2 final recs. Okay, so first is that there is an app that you can download for your phone. It's SCCM Point-of-Care or POC. And so you can download that and then it's got the whole Surviving Sepsis Campaign Guidelines on it. And so you can, scroll and search by different types. So that's it. They're big. There's lots of recommendations, but that's one tool to help you easily navigate it and have it at your fingertips. And then the second is I want to put in a plug for a book. You guys were talking about books and Bram got that question, but there's a book called Blood Poison, The Untold Story of Sepsis that is coming out this summer. So it's available for pre-order now. And I got to read it ahead of time and do a review for it. And so it was really awesome. The first about half of the book is really just this kind of ancient history, when was sepsis first mentioned in Greek literature and all this kind of stuff and germ theory and antibiotics and kind of all this medical history stuff. And then the sort of second half of the book is all the kind of recent stuff, right? The Surviving Sepsis Campaign Guidelines, the, sort of policy fights over SEP1. And so I think it just does a great job of kind of contextualizing everything and giving this kind of long arc story of sepsis and kind of where we are today. So I recommend checking that out when it comes available this summer.
Excellent. Well, I want to thank both of you for all the work on the guidelines, but also for being so generous with your time and with your knowledge. I definitely enjoyed the conversation and learned a lot.
Yeah, thanks so much for having us.
Thanks, Sergio.
Thank you for listening to Critical Matters, a sound podcast. Make sure to subscribe to Critical Matters on Apple or Google Podcasts and share with your network. Sound's transforming the way critical care is provided in hospitals across the country. To learn more, visit www.soundphysicians.com.